All right. Good afternoon, everyone. As most of you in the room are aware, this is our Timothy A. Johnson Medical Scholars Lecture Series, where we invite physicians who are actively practicing, clinician who also do research. And we always love physicians like the one you're going to hear from today, because they're able to take what they see in the clinic and use that to inform their research. So I will let Dr. Epling introduce our speaker today.
Hi, I'm John Epling. I'm Vice Chair of Family and Community Medicine for Research and Population Health. And I'm here to introduce my friend and colleague, Dr. Anthony Viera. He is the Leonard J. and Margaret Goldwater Distinguished Professor and Chair of Family Medicine and Community Health at Duke University and Duke University Medical Center. He is board certified in family medicine. He's also got specialist certification in clinical hypertension from the American Society of Hypertension, which I don't know how many family docs have that, but that's pretty cool. He graduated with a BS from Wofford College in Spartanburg, South Carolina. Go Terriers. No. Graduated from Medical University of South Carolina with his medical degree in 1996. Went to U.S. Naval Hospital, Jacksonville, Florida for his family medicine residency, which is where we met. Graduated there in 1999. From there, went to UNC for a Robert Wood Johnson's Clinical Scholars Program Fellowship. UNC Chapel Hill, including an MPH, which he completed in 2006. He was on UNC's faculty from 2006 to 2017, where he did lots of his work. And then in 2017, he applied for and obtained a professor and chairmanship at Duke University in 2017. I'm told, like the Wofford Terriers, Duke also has a basketball team. I've never really heard of it. Dr. Viera has 197 peer-reviewed publications. He is amazingly prolific in both research and as family docs do, a wide variety of clinical topics. He has over 30 book chapters, books, and monographs. And if I enumerated all of that stuff, we'd be here for more than the hour we have. I'll sum up by saying that he's a reviewer for NHLBI and several other study sections, both federal and foundation. He's got numerous awards for research and teaching, including AOA, American Alpha Omega Alpha Society, as well as the Delta Omega Society, which was an honor society for public health. He served on national committees at the American Association of Medical Colleges, Agency for Health Research and Quality, American Heart Association, American Society of Hypertension. He's mentored over 120 learners, MPH students, medical students, graduate students, and junior faculty on K Awards, research papers, grants, dissertations, the lot. He's been funded on many projects. I did not calculate his overall funding total. However, he's had at least 3 R01s that he's been PI on and multiple other clinical studies that he's been on. His research is focused on hypertension, both the clinical measurement of hypertension, which we'll talk about a lot today, as well as treatment and cardiovascular risk reduction more generally. My favorite thing on his CV is that he's got a teacher certification from Winthrop College in South Carolina. So if this whole chair at Duke thing doesn't work out, it's a solid fallback. So I think that's good. Well, maybe a retirement plan.
Yeah. I was also a soccer coach.
And then at dinner last night, we talked about a possible new line of research, maybe a dose-response relationship of broccoli intake and hypertension.
Yes.
We'll have to see. So, Dr. Viera.
Thank you, John. Well, thanks, Dr. Epling, for the gracious introduction, and thanks for the invitation to be here with you all. It's a pleasure. I'm going to dive right in. Here are the objectives, which I won't read to you, and the disclosure slide. This is the starting point, office blood pressure. It is the measurement for our most basic diagnosis, the most common thing that turns an ordinary person into a patient, which is hypertension. Yet, it is challenging, and it's mostly done wrong. Accurate measurement is challenging in busy office practices where patients are rushed in and rarely follow protocol. Mercury is no longer used, yet we still call it millimeters of mercury. We use oscillometric devices that actually take a mean arterial pressure, and every company has its own algorithm by which it converts mean arterial pressure into a systolic and a diastolic blood pressure. Limitations of office blood pressure, as I alluded to already, a poor quality control due to technique. Notoriously, there are the wrong size cuffs. The one you need is in some drawer somewhere and you cannot find it. And that when you do find the cuff that it's improperly fitted, or you go in there and it's slipped down the arm and it's measuring elbow pressure, the patient's in improper position with feet not on the floor, arm not at heart level. Rarely do we allow the 5 minutes of rest because Dr. Viera is ready to see the patient, and please get the patient in the room. And there's this common thing where we'll just use the manual sphygmomanometer because everybody believes that more, right? So, and then when you do that, it's introducing a whole other host of variables, including letting air out of the cuff too rapidly. Can you see the dial properly? Can you hear the carotid cuff sounds? And if you can, which ones do you use, fourth or fifth? And then because you can't see that dial so greatly and it's not really calibrated all that finely, there's a lot of rounding to 5 or 10. And that's been shown in multiple studies. Now, let's just assume you could do it correctly in the office, even if you could, or when we do, because sometimes we do get it right. We still have this problem of it's only 1 or 2 readings. And is that really reflective of what someone's blood pressure pattern is when we know that there's huge variability, both inherently, our own physiology, and external factors? If your bladder is filling while you sit listening to this lecture, your blood pressure will rise 20 millimeters of mercury. We've known this for a long time. Jeffrey Rose is a famous epidemiologist, published a paper in 1966 where he showed the variability of measurements of casual blood pressure, that you just depends on when you catch the person as to what their blood pressure reading will be. And so we have a lot of influence that's causing blood pressure to vary. And that is why our usual practice, supposedly, is to base diagnosis of hypertension on office measurements that have been repeated over time, ideally multiple times in the clinic visit and over multiple clinic visits. Yet studies, papers after paper, have shown there's a lot of visit-to-visit variability in that as well. And strict repeat measurement protocols are rarely followed, and they vary from clinic to clinic. They probably vary from one Duke primary care clinic to the other, even though we try to standardize it. So we're after a moving target. And even when a particular measurement is accurate, it may not reflect the person's usual blood pressure, what I'm calling the true blood pressure in this slide. So let me give you a clinical scenario. This is a real patient, 51-year-old woman with elevated blood pressures times 2 visits. If you average her office visits, office measurements, they're 155 or 83. Her BMI is 24. She's got no signs of target organ damage, such as LVH. Her LDL's, HDL is good. She's not diabetic, doesn't take any medications. Came in here thinking she was healthy and fine. And so now the question is, does she have high blood pressure? Are her blood pressures accurate? Assuming they are accurate, do they represent the patient's usual blood pressure? And are you ready to make the diagnosis of hypertension and start medications? Are you ready to turn this woman into a patient? And here, of course, the problem is that clinical blood pressure can overestimate her usual BP, and that's what we're fearful of in this particular context. And you all know about white coat hypertension, the problem misclassifying the white coat effect as actual reflective of true blood pressure pattern and misdiagnosing hypertension, when in fact, if you were to really measure blood pressure over multiple times in this woman's life, maybe it actually isn't elevated. So that's what we're worried about here. We're worried about overtreating and harming, prescribing medications when they're not needed and turning people into patients. And we do know from multiple studies that just the diagnosis of hypertension makes people feel worse, causes more missed days at work, and causes more depression, more marital discord. So it's not just the label itself does harm. And what do we know about white coat hypertension? It is quite common. About 25% of clinic hypertensives have white coat effect or white coat hypertension. And the prognosis, as I've alluded to, is relatively benign. Yes, there is some risk. We'll look at that. But importantly, drug treatment has very small effects on the ambulatory blood pressure of patients with white coat hypertension. And actually, in all patients, it's hard to move the needle on 24-hour blood pressure. And therefore, drug treatment may not be effective for white coat hypertension, even if it does confer a little bit of risk. All this is to say that ambulatory blood pressure monitoring has been the standard method to confirm white coat hypertension. What is that? It is when the blood pressure the patient wears the blood pressure monitor for 24 hours. It is pre-programmed to take readings, usually every 30 minutes during the day and night, although sometimes we spare the patient the nighttime suffering and make that interval longer. But it is cumbersome. You have to wear it, and it has tubing, and it makes sound, and it constricts the arm. It is a brachial cuff. The wearer cannot see the readings so as not to alarm the wearer, and the wearer is instructed to go about mostly normal activities. Obviously not shower or swim with the thing on, but really, if you go to the grocery store, you can drive, you can do your normal activities, you can even go for a walk with your dog. Just simply, if your arm is elevated because it's on the steering wheel, when the monitor beeps, you know it's going to take a blood pressure. You will try to relax the arm, maybe put it in your lap so it doesn't get a misread. Because if it misreads, it's going to fire off again until it gets a read, or 3 times it's gone off. So that's the way that works. From all of that, you do get good data. You get a lot of data. You get 40 plus blood pressure measurements, from which, as you can imagine, you can calculate mean blood pressure overall. You can calculate the mean awake blood pressure. You can calculate the mean sleep blood pressure, which turns out to be very important. You can calculate how much the blood pressure dips at night. You can calculate the blood pressure load, which is the percent of readings above a certain threshold. You can do a lot with it. Here's what a particular graph or printout looks from one particular ABPM software. This, you can see the top line represents systolic blood pressure. The bottom line represents diastolic blood pressure. You also see the heart rate there. You can see the green is just the threshold, identifying the threshold. You can see this pattern is quite good. A couple of spikes above 140, but otherwise looks really good. You can see the nocturnal dip during in the shaded area, which is the sleep time. And you can even see the morning surge when the patient, the alarm goes off and hits the snooze button, finally gets out of bed, the cortisol rises, and you go take your shower. With the blood pressure machine off, if you take a shower. Patients will do it. I learned it over doing 1,000 plus of these things that, yes, even though you instruct the patient to wear it for 24 hours, I personally would want to take a shower too. So you take it off, and the trick there is teach the patient how to put it back on correctly so that you still capture data, and teach them the window of when to take the shower. Important to note, cutoffs for ABPM averages are different than our office. Because it's accounting for this idea that out of the office, you should mitigate the white coat effect, and therefore awake average for a blood pressure ABPM wise is 135/85. Nighttime you should dip, so the nighttime sleep average should be 120/70 or less. And then when you take all that together, we talk about a 130/80 being the cutoff for a 24-hour ambulatory blood pressure monitor pattern. The task force looked at this, as did the UK NICE guidelines, European Society guidelines, et cetera, looked at the value of ABPM first to decide, okay, does it predict anything? Is it better than office blood pressure? And the task force, back when they published this paper in 2015, they found 9 studies that evaluated the predictive value of 24-hour blood pressure on long-term health outcomes. The studies had to follow a cohort of patients, and they had to report the hazard or risk ratio over time. They had to have at least 2 blood pressure measurement methods at baseline, like ABPM and office. And then the outcomes, importantly, were overall mortality or CVD events. Without going into the whole paper in a lot of detail, I just want to say that the systematic review did find that for each 10 millimeter mercury increase in ambulatory blood pressure was significantly associated with increased risk for fatal, non-fatal stroke and cardiovascular events. 11 to 42% was the confidence interval there. Now, the important point of this is what's in the green. That's adjusted for office blood pressure. So when you have ambulatory blood pressure data, it doesn't even matter what your office blood pressure number is. It's the ABPM that matters. So the guideline from the task force said, and this came out in 2015, evidence supports ABPM as the reference standard for confirming elevated office BP. So let's go back to this patient. 51-year-old woman, you remember her, had a 155/83 in the office, but she looked otherwise clinically well. And here's her ABPM data, and what you can see is a marked white coat effect. That first blood pressure is 180/110 or something like that. Back in the day, it's like the nursing staff gets panicked and they were given oral clonidine or something even stupider than that. But if you actually watch her over time, this pattern actually looks quite good. White coat effect goes away when she's not anxious about being in the doctor's office. Blood pressure settles in. She has a nice dip. And she has another spike maybe during going to work or something, or going on a lunch break or something. But this looks really good. And when you average all the data, mean overall 130/79, mean awake 134/83. So, on the cusp, but overall blood pressure load's only 17%. So not a lot of blood pressures above the threshold, has a nice normal nocturnal dip. She has white coat hypertension with a pretty marked initial white coat effect that settles in. So the question there is, do you even treat it? I call this office blood pressure a false positive, as you would, right? When you dichotomize a screening test and you then apply a gold standard, or at least a silver standard in this case, and it's wrong, then we call that a false positive. Now, here's where sort of I got interested in this, is where it gets interesting to me. So there's not just white coat, and the task force says ABPM to confirm an elevated office BP. But couldn't office BP also be a false positive? Task force doesn't say anything about this, doesn't say we should apply this to everyone. And I agree. Why would you just, if someone's blood pressure is 110/60, I certainly am not going to subject them to more testing to think that's a false positive or false negative. So let's take another patient, 34-year-old physician, another real patient, by the way, not exercising regularly, drinking 1 to 2 glasses of wine most nights, taking a statin for hyperlipidemia, office BP 128/78. So the question in this case, how certain are we that he does not have hypertension? And I love 2x2 tables. Dr. Epling can vouch for that since I was a resident. And you could then take office blood pressure and put it on one side of a 2x2 table and put ABPM or home blood pressure monitor on the other side, and it's going to yield 4 cells. They're both normal. That person has sustained normal tension, so they're normal. If they're both high, person's in the red, they have sustained hypertension. We talk about the normal and normal outside the office, high in the office, that's the white coat hypertension. And then there's the other cell. What about them? Normal, could it be normal in the office, but actually high outside the office? Here is this doctor, emergency room doctor, by the way. And this is, we try to do ABPM on a work day. So this is a work day, and you can see this blood pressure is not so good. Multiple blood pressures that are 150s, 160s, even 170s. A mean that's 136/79. Awake, oh no, yeah, that's the overall. The awake is 142/84. Sleep 109/51. So at least when this physician goes to sleep, the blood pressure normalizes. That's good news for him. Why does it matter? And there are multiple studies on this. I'm going to show you a couple. This is a study that was done in Japan, followed folks, 1,300 individuals over 10 years, and looked at each of these phenotypes. And so if you look at what you're seeing here is the bar on the far left of the screen is sustained normotension. Those are the always normal people. Normal in the office, normal outside the office. The bars on the far right are sustained hypertension. Abnormal in the office, abnormal outside the office. The bar just to the right of the 1.0, the reference is the normal, is the white coat hypertensive group. The confidence intervals, as you can see, cross 1. There is a slight increased risk, but they're pretty much no difference to the white coat group. But look at the mass group, which is the third bar from the left. It pretty much is the same as sustained hypertension. I mean, it's really close on CVD mortality, stroke, and the combined event rate. So that's why we think this is important. So this is another study published in 2007, looked at the same thing. When you look at masked hypertension versus normal tension on the left, sustained hypertension versus normal tension on the right, you see that they are pretty similar. Confidence intervals even overlap. Here's yet another one showing the same effect. Normal tension is on the 1.0, hazard ratios continue to increase down to sustained hypertension, with a line that can be drawn between masked hypertension and sustained hypertension, showing that those intervals overlap and the risk is there. So that's masked hypertension in that cell down below. So they're color-coded sort of to indicate risk. Normal is the green, you got the go light. White coat, you got a little bit of risk, but not much. Sustained, you got the most risk, but masked, that probably ought to be a little more red. Like that's kind of salmon or whatever color it is. But I'd probably make, if I had the color right, I'd make it a little more closer to the red, because there's risk there that's pretty close. And it makes a lot of sense. Think of it's like a dose response of blood pressure. The more your target organ are seeing of high blood pressure, the more likely you are or it to confer risk. The trouble is when the office blood pressure is normal, we stop there. Why go looking for trouble? I hit my metric, blood pressure is normal. I'm not going to try to convince this patient to do more. So while we're overcalling some, the white coat folks, we're missing those with masked. And the question would be, what would be a good way to identify those patients? One possible strategy would be everybody gets out of office blood pressure. That's probably not practical or feasible. And truly, there's probably some level below which you're like, no, that it really is good. And you'd have to move so far up to have masked hypertension that it doesn't make sense. That's one idea I had. And the other would be to then, okay, could you identify factors associated with masked hypertension and pursue those? So that was the basis of my first R01, which was the North Carolina masked hypertension study. One of its goals was to examine the reproducibility of masked hypertension, because one of my first thoughts was, well, if it's not reproducible, we can't predict it because it's just reflecting variability, which is part of the problem with blood pressure I've been arguing since the beginning of this talk. So if it's just that, then it's not predictable. And so why even go after predictors? So that was the first part. Is it reproducible? If it is, if it's a real phenotype and there's some real mechanism for why when Anthony's sitting in the doctor's office, his blood pressure is lower than when he's actually working at his chair job, which I believe is true, by the way. I haven't checked that, but it's probably true. Then is there a way to identify that? If it is reproducible, is it predictable? So again, I continue to wonder about just random variation, which is why the first part of the specific aim is there. So I constructed this model like you do with any good grant proposal. And the idea being, okay, masked hypertension could also develop such that if you waited long enough, the person would declare him or herself, right? Just come back in 6 months and maybe that blood pressure will cross the threshold. Or if it is truly random, I'll just happen to catch it at an upswing instead of a downswing. So you start with normal office blood pressure on the far left. And if you go straight through, the next visit could be normal. The next visit could be masked. But if you start adding in, okay, normal office blood pressure and then elevated out of office blood pressure, that's masked hypertension. And then we're missing that because we're still seeing them as normal, and then masked is happening in there. If they do go to elevated blood pressure, we're catching them. The end result on both is target organ damage. Here I've shown LVH, left ventricular hypertrophy, albuminuria, subclinical atherosclerosis, which then of course we care about because they lead to CVD events. So those are the two paths following a clinically normal office blood pressure measurement. And then I said, okay, what are some possibilities that could explain elevated out of office blood pressure with a non-elevated in office blood pressure? So you think about the usual things, demographics, sex, race, age. What about clinical factors? Smoking, obesity, high pulse rate. Psychosocial factors were something I really thought would drive some of this. Think about the emergency medicine physician, job or home strain, perceived stress, trait anger. Could socioeconomic play a role? Those kind of things. So that's the model. So here again are the aims. I wanted to estimate the prevalence of masked hypertension and its reproducibility using ABPM as the gold standard. You'll see I also incorporated home blood pressure monitoring in this study. And I chose a specific population, those with a recent borderline primary care office BP. And the reason I chose borderline is because if this were a true entity, and we're going to make the case that you need to start testing people with normal office blood pressure, you want to make the case that it won't take much for them to cross over to have hypertension. Go back to the example I gave you. If someone is blood pressure is 90 over 60, it is really unlikely that even if that's wrong, it is that wrong. Similarly, if the blood pressure is 200 over 100, yeah, it could be wrong. But if you measure it again as 200 over 100, and the patient has a displaced point of maximal PMI, has no pulses, no hair on his toes, the guy's got hypertension, just treat it. You don't need to do other things. So that's why I chose the borderline group. And that becomes important when you think about when you'll see the prevalence in a few minutes. So the second goal then was to identify factors that could predict MH, what would be associated with it. So here's how we designed the study. Again, we talk about the eligible people. They come in because they had a primary care blood pressure that was on the borderline. There was a step level to this because in the office, blood pressure is more crudely taken. In a research setting, it's more controlled, which means the research setting blood pressure tends to be lower than the office blood pressure. So that means you have to have a step progression to when you kick somebody out of your study versus we allow them to continue to be in it. So we had that all built in. And then they came into our research center. They did visit 1, where we measured a bunch of stuff. And then we fitted them with an ABPM, which they wore for 24 hours. Then they came back the next day for visit 2, turned in their ABPM, and were issued a home blood pressure monitor, and were instructed on how to take their home blood pressure for the next 7 days. And they came back a week later for visit 3, at which time they got a second office blood pressure ABPM pairing. They were fitted with an ABPM monitor again, wore it for 24 hours. Came back the next day, had the monitor taken off, HBPM issued again, and came back 7 days later. So that's how long they were in the study. And the obvious point here is reproducibility. Is it reproducible in the short term? And it's important to say short term because you don't want, how far out, again, go back to the natural history of this. At some point, it's going to cross over because of the natural history of high blood pressure. So it's the short term makes the most sense to me, which is why we did it that way. Actually, you look in the literature, there's a couple of papers on this that look at the long term reproducibility of this, which I'm not so convinced. So here's the kind of a summary of the BP measurements we had. We had office, we had research clinic blood pressures ×3. We had the ambulatory blood pressure monitor, which was a validated monitor. We did it again, had the home monitoring. It's just a word slide of what I just went over. We also, of course, had to measure these other things. So we did an EKG on them to look for LVH. We also did an echo to look for LVH more carefully and could quantify it in left ventricular mass index. We measured urine microalbumin, serum glucose, total and cholesterol and HDL. We did high sensitivity CRP just as another marker of inflammation, possible indicator of CVD. Coronary artery calcium we offered, it wasn't mandatory. And then folks filled out surveys. We did a validated caffeine intake questionnaire. We did validated state and trait anxiety questionnaires, trait anger questionnaire, the Carastic job content and job strain questionnaires, the perceived stress index, the home life pressure index, measured health literacy, health numeracy. We even asked how many children were at home, how many children under 1, how many children under, those kind of things to try to get at home stress, home life. Here's the demographics of the 420 participants. 40, you can see the age grouping there, pretty wide age range. I think our oldest participant was 81, 44% male, 21% blacks. Most works outside the home. 2/3 were married or partnered. Low smoking rate of only 7%. So interesting. We had a 72% indicated drinking some alcohol. We had a breakdown of this more carefully too, but for this slide, this is all we really needed to put on here for you to get where I'm going with this. And then BMI stratification, nearly 3/4 had at least college education. Not so much target organ damage because, again, they're folks with recent borderline blood pressures, not been diagnosed yet, but there was a little bit of LVH. 21% had some coronary artery calcium on their CT scan. Again, not everyone did the CAC scan, but a lot did, 321 out of 420. And here's the prevalence data. So that's why I said it's important to know that these were patients with borderline office blood pressures, because when you talk about a 50% prevalence of something, but again, it makes sense when you look at the numbers. If I'm taking somebody on the borderline of something, totally makes sense that half, when you do ABPM, would flip over to the top line and half would go to the bottom line. So that's how I explain the high prevalence of MH in this study. And then another thing I've always liked is the kappa statistic. So remember, kappa is, you can agree on something simply by chance. I could listen to the lung fields and say there's crackles. John Epling could listen to the lung fields, say there's no crackles, or he could say there are, and maybe he can't even hear, but he would agree sometimes just by chance. So kappa corrects for that. You take your observed agreement minus your expected agreement over 1 minus your expected agreement. 1 indicates perfect agreement and 0 indicates pretty much chance agreement all the time. So when you report agreement, you should report both the observed agreement and the kappa. So we had an observed agreement of 69% and a kappa of 0.38 that was significant. And this was with the awake ambulatory blood pressure average. We broke it down by awake, overall, nighttime. I have the home data compared to the ambulatory data. But for purposes here, this is sort of showing that a 0.38 kappa, it's fair reproducibility, not great. But the side note I wanted to share was that you never know what's going to happen as you move through research career. This was a paper I wrote while I was a fellow on understanding the kappa statistic. It's been cited almost 10,000 times. It's my most cited paper. And it's probably given this journal its impact factor. So you never know what's going to happen. And it's because it's a methods paper, and I think hopefully I broke it down in a way that makes it easy to understand. But I also credit Dr. Epling for, inspiring my love of kappa. Mass hypertension phenotype then, it's fairly reproducible, 0.38. Is it predictable? My next question. Because if it's predictable, then that can guide who among our patients with a normal office blood pressure should receive out-of-office monitoring in a feasible, cost-effective manner. So you're not doing it to everyone. You're trying to maximize the yield. So this talks about prehypertension as a predictor. So you can imagine the idea here is the closer you are to the borderline in the office, the more likely you are to cross, which is what I indicated earlier. While if BP is quite low in the office, it would make you much less likely. So what we did for this particular paper is we took a subset of the 294 with a research office BP that was less than 140/90. Because you remember, for reproducibility, it was also possible that someone could have any of the 4 cells at the first time. So I wanted to allow for the fact that they could have sustained. That's why I allowed 140, greater than 140/90 at the beginning. And they could go from sustained to white, or sustained to mass, or mass. So that I wanted to account for that. That's why it spanned the threshold. So that's why this is only 294 people. Those are the ones who had the initial blood pressure less than 140/90. And we simply calculated sensitivity, false positive rate, likelihood ratios throughout that range of cutoff BPs from 110 to 138. Just as quick reminders, things I love, but not everybody does. Sensitivity is the proportion with mass hypertension who would be detected. The false positive rate is the proportion who would screen positive but not have mass hypertension. That is, they would have a normal ABPM. And the likelihood ratio, the way I think about this is the how many times more likely the screening result will be found in those with over those without. That's how that works. And these are just data from that paper. And I really just blocked here in green what to look at. Yes, if you use a cutoff of 110, it gets to my point earlier, your sensitivity will be high. You'll catch a lot of people, but your false positive rate will also be high. But as you can see, it doesn't really get much better. Like, things don't really happen much on this, and it's really apparent in the ROC curves. The bend of the knee in this ROC curve is about 126, indicating that's probably the best cutoff point if you are to say, you know, the idea here is reflecting the trade-off between sensitivity and specificity. You want to reflect that trade-off. Yes, you can. This is how we move test cutoff. You can move it down if you never want to miss something. Like, you could admit every patient that comes in the emergency room and you maybe never miss an MI, but that's silly, right? We don't do that. So it's a good way to think about sensitivity specificity. The ER is designed to be very sensitive. They don't want to miss anything, while the wards are designed to like sort things out and be specific, right? And so that's where this kind of comes in. The ROC curve reflects the trade-off. So in this case, prehypertension or blood pressure ranges didn't turn out to be all that great at being able to predict this. Again, likely explained by the variability of blood pressure. So then what are other factors besides blood pressure that maybe could explain or help in a model? Maybe you could do model this out, use a regression model or something, where you'd say, what are some associations? All the things you remember I measured, could those actually be better predictors of ABPM? So we put those in a model containing blood pressure alone, compared to the model with blood pressure plus other potential predictors. And remember, I had all these: age, sex, race, ethnicity, smoking status, education level, alcohol use, BMI, heart rate, caffeine intake, state trait. We looked at all of this stuff. And in bivariate, few things were significant at a p less than 0.10. And I used p.10 because in this idea of taking your bivariates, and you want to make sure you maximize the potential for your model to find something. And it turns out only younger age, male sex, and working outside the home were significant with mass hypertension. And when I added those to BP, it didn't help predict any better. BP, it turns out, was the best predictor, and adding these other things didn't work very well at all. So it goes back to this point, well, the closer you are to the hypertension threshold, the more likely you are to have hypertension, right? So prehypertensive office was the best office blood pressure predictor. And this also goes back to a point I made years before I even started this research, was when JNC7 came out with the term prehypertension, I disliked it. And that's putting it mildly. I disliked it because everybody's prehypertensive. If you live in this country, you're prehypertensive, right? 90% chance you're prehypertensive. And so that seemed silly to me. But they were talking about, well, there's risk with prehypertension. And so then I started making the case, well, that risk was because it's that prehypertension, you're measuring something in the office, calling it pre, when if you were to measure it outside the office, a lot of those folks have mass hypertension, which, as we already showed you, has a risk that's almost the same as sustained hypertension. So prehypertension is simply probably a way to say you're identifying people who are more likely to have mass hypertension. And there were no association with race, body mass index, marital status, education level, income, smoking, caffeine, state anxiety, trait anxiety, kids under 1, perceived stress, heart rate. None of that panned out as a predictor. So the way I broke this down clinically then is, well, you consider looking for mass hypertension in those with a borderline blood pressure with other risk factors. So if someone comes in with a borderline blood pressure and they have a family history of early heart disease, or they have hyperlipidemia and diabetes, maybe that's a group in which it might make sense to look for it. But the problem is there are no RCTs of treatment of mass hypertension. One might make the case that, well, you don't really need that because mass hypertension is hypertension, right? You just caught it at the wrong time. which I think that's probably legitimate. You can make a case. We also don't really know the natural history, how many will declare. And if so, how long of delay will that declaration take? Meanwhile, is Rome burning? Because if middle-aged men don't come to the doctor, maybe that one time at age 40 because of work reasons was the one time they came in, or because of some back injury, and that's when you had the chance to diagnose it and you miss it, when's the next time they're going to come in? So these are the reasons why it might be important to look for this. Practically though, despite years of data, the task force saying, yes, ABPM, it's not widely available, hard to get. I had a hard time getting it at UNC, so we started a service, and that allowed some people to get it while I was there. I had every intention of starting a service when I got over to Duke, but because of so many other things I have to do in my day job, I haven't yet gotten that off the ground. Few providers and clinical staff are trained in this. And so what the task force did, when they issued their initial recommendation, it was ABPM, do that. Well, then, and they have how many months? 6 months of feedback from the public. I think it's like there's a public comment time. Yeah. And so during that time, there was a lot of comments that, well, I can't get ABPM. Home blood pressure monitoring is another way to do this. And so the task force did come back and say, yes, when ABPM is not available, home blood pressure monitoring should be used to confirm a diagnosis. It's also recommended during a work day, which is not always easy to do. If I were wearing the monitor right now, because for some reason I had to, every 15 minutes, you'd hear this sound burn. We'd be measuring, it'd be uncomfortable, awkward. So it's not always feasible. It does limit some physical activity. You can't do heavy manual labor while you're wearing it. And while tolerable, it is inconvenient. And if you have a session of 24 hours and for some reason the monitor has a glitch or a blip, you'd have insufficient readings, which you'd have to do a repeat, and nobody wants to do that either. So there's a lot of practicalities with it. We looked at tolerability in our study because since we had data on people we had people who were wearing it twice in 1 week, we said, okay, let's see how they tolerated this. And so we developed a survey, and 67% reported that the monitor woke them after falling asleep, which you can imagine. That's not hard to imagine. 8% removed it at some point during the night because it was aggravating. And there's talking about bruising, and because if that thing's going off all day long and then you do it again a week later, there's a lot of constriction on the arm. So people had bruising, discomfort, skin irritation. So again, it's not without harms. So home blood pressure monitoring is another way to go. Outside the clinical setting, you can get measurements. It's also a better predictor of outcome than office blood pressure. So the task force does have all that data. The best strategy for implementing home blood pressure monitoring is still a question. It's still work I'm working on with colleagues on, do you really need 5 measurements? Do you really need 3 morning, 3 evening, 5 days in a row? Can you lower that and make it more feasible? Those kind of things are still kind of out there. This, by the way, is showing you that the prevalence of mass hypertension by home blood pressure is much lower. And again, it's much lower probably because you're missing a whole segment of the day. If you're asking people to do, as we do, 3 in the morning, 3 in the evening, well, you're missing the entire ER shift that doctor was working, right? So that's why you're probably missing that. Another thing I like to sort of end with when I think about ABPM is that ABPM is actually different than office blood pressure, isn't it? When you're doing it in the office, as I started the talk, you have them sit, wait 5 minutes, put their feet on the floor, have their back supported, and have them under calm conditions, like the strictness of it. ABPM is performed, as I said, during your real life, during your work day. Which part of this is what your target organs are seeing? When you're sitting there calm, or is it seeing all of your daily life? And so is that why ABPM, partly the reason why ABPM is a better predictor of what's going on with our physiology, with our body. Last thing I want to conclude with is that this is all kind of false anyway, isn't it? I'm dichotomizing a continuous variable. That's what we do for convenience and to make a diagnosis and to turn people into patients. When in reality, the relationship of blood pressure to events, we also know is continuous. And no matter how old you are, for every 20 millimeters of mercury systolic, you increase the blood pressure starting at about 115, the risk, IHD, whether that's ischemic heart disease mortality, stroke mortality, the risk doubles. No matter how, and so yeah, the absolute risk is higher as we get older, because as you know from your ASCVD models, age is one of the biggest drivers of risk. And so that you can see that in this slide. So it's not really dichotomous, but we dichotomize it to make life easier, to separate those at higher risk from whom treatment is warranted, and really treatment, quote unquote, by giving people blood pressure lowering medication when they don't feel bad or have any condition other than this diagnosis we're giving them is really a prevention intervention. So we're really trying to just separate out people for whom a prevention intervention in the form of pharmacotherapy conveys more benefit than risk. That's what we're trying to do. And so one could say, well, yes, we started moving this down, we started seeing the risk, but there's some point at which like it doesn't make any sense, right? Even though it's a continuous variable, doesn't make any sense to start medication. So that's kind of what we're doing. The future, and why might I just give up on looking after this and talking about phenotypes of blood pressure? And it's because we're moving toward cuffless devices that you can wear all the time. The ability to measure blood pressure continuously it's here. It's getting better. We're moving from aplanation tonometry, which is when the little bell has to sit right on the radial artery. And if you just move it a little bit, it will not give you any good data, to things like how far a temporary tattoo displaces the skin and converting that into a blood pressure. There's patches that you can wear or that will be out. There's glasses that will look at the back of the retina, measure blood pressure. There's an app that will look at the color of your face and estimate blood pressure. So there's things coming out. I call it watches, patches, glasses, oh my. And I save this to the very end because I know you'll Google it. There's even a toilet seat that will measure your blood pressure. So Google it in a few minutes and you'll check it out. And so I don't know, it's like measure your blood pressure, your weight, your pulse ox. I'm not sure that's the opportune time to measure one's blood pressure, but anyway, it's out there. And then these data will be fed to, to the clinical office or some method to say when somebody's risk is high enough to justify treatment and probably obviate the need for these one-off blood pressure problems. And so we're getting there. And the cuffless devices will also be much easier to wear and able to get people to do than the 24-hour ABPM. So I'm going to stop there and think about your questions, and appreciate you having me. I had a lot of fun sharing this early work that I did. Hard to believe it was over 10 years ago when I did that, but.
Thank you so much for sharing. A question that I had when we were going through these papers is when we see those spikes in blood pressure, like you were showing on those charts, why is that always something that we're worried about? If this was an athlete that we were seeing going through performance, those spikes in blood pressure would be something that would be expected. And we still encourage people to exercise regularly. So how much is what we're looking for pathologic versus something that we would actually want to see in a healthy patient?
Yeah, it's a great question. That's one of the inherent, those external variability factors that I talk about that's like raising blood pressure, and why, like when your bladder's getting filled, that's not a problem. That's your body's natural response to my bladder's filling up, blood pressure goes up a little bit, go to the bathroom, it gets better. So I think that's partly why the 24-hour ABPM data or things like the future of continuous blood pressure measurement will allow us to really identify risk better than the one-offs. Because the one-offs could be reflecting these things that are just externally causing our blood pressure to be high. When in fact, yes, you're deadlifting 400 pounds. I read those blood pressures can be really, really high. Yes, we get the front here.
Thank you so much for your presentation. I was wondering a little bit about the 24-hour average in terms of like the mathematical formula for how do you really determine the most significant periods or the significant weight of a given period on its effect for secondary organ damage, et cetera. As well as kind of, I kept going back to the sleeping data as like the great equalizer in a sense of, at least that is the constant to some degree for a lot of individuals or all humans. And kind of like the weight of the sleeping data as potentially the most standardized to kind of move forward with at least continuous external blood pressure monitors.
It's so interesting you asked this question. I just had a call 3 or 4 days ago where what we did with this data set, which I didn't tell you about, was we applied for another R01 in which we combined my data set with 4 other data sets that have ABPM, home monitoring, and echo data, so we can get LVH. We just talked about writing a paper from the pooled data set in which we compare exactly the problem you're saying, because some protocols to give people a break will space out the nighttime to 1 hour. Now, all of a sudden, you're treating daytime measures as greater weight than nighttime measures. So we're going to do a paper. Our plan is to compare weighting the average versus the way we treat it clinically, as if you just slice it over in time and average it out. And then looking at the correlation of those with left ventricular mass index to see, does it matter? Like, what is the effect of averaging it all out, which is what a lot of the software does, doesn't give you the weights. Or should we be giving the weights? Does it matter to give those weights? Obviously, our hypothesis is that it won't do too much, but will there be something there that if you use the weights, you start categorizing them just a little bit differently, and is that correlating differently with target organ damage? So it is a super good question, and we hope to have an answer soon on the effect of the weights. Some protocols do actually explain how they weighted their average or their calculation. We looked at this in a systematic review. 2/3 of papers using ABPM do not explain how they did it, including mine, I don't think. So again, I'm guilty as charged.
Thank you again for your presentation, and apologies if this comes across as ignorant, just trying to understand. How do we know that the white coat effect is being ruled out in this setting? Because for these patients, especially because we see a strong correlation with people who are working outside the office or potentially have a different an anxiety disorder coexisting with this masked hypertension, it seems like these are individuals who might be stressed out essentially by having the blood pressure taken continuously. And not to mention what you pointed out about the tolerability with individuals waking up frequently over the course of the night. It seems like that would raise blood pressure as well.
Right.
So all of that being said, of course, even just knowing that this information is going to your doctor is also kind of part of the white coat effect. So how do we know that this measure is authentic for this masked hypertension?
Right. Again, I think that's an excellent question. It's like what is causing the stress that is causing the blood pressure? Like, or when is the stress happening? If that's the true mechanism that's causing the blood pressure to rise. If it's happening in the doctor's office, we say it's white coat. If it's happening at work, we're calling it mass, when in fact the pathophysiology might be exactly the same thing. Stress driven, hormonally driven, causing the blood pressure to rise. I think the difference is the amount of time it's doing it. Right. In the 24-hour pattern where you see the white coat diagnosis, it's only doing it in the doctor's office, and the average actually is quite good, whereas the other is flip-flopped. The normal is only happening rarely, and the spikes are happening a lot. So that's kind of the flip-flop. And therein, I think, lies the stratification of the risk. It's like a dose response. The more blood pressure spikes you have, the more time you spend in high blood pressure, the more likely you are to have an event. That's what it looks like from the graphs anyway.
All right. I promise not to quote you if you offer any interesting opinions, but two-part question. There's heterogeneity about the guidelines for diagnosis and treatment of hypertension. I'm curious to where you fall, especially about that last couple of slides there where you talked about different risk levels. So where do you fall on the guidelines for diagnosing and treating blood pressure, the treatment targets? And then what do you think, or is there a fair metric by which to measure physicians on the quality of their blood pressure control?
Excellent questions. So to me, the answer for the blood pressure threshold and how I approach it in clinic is it depends. And that may sound like a cop-out, but it's the real way I practice, because the idea would be if someone is low ASCVD risk and their blood pressure is a little high, I'm going to give them more time to work on lifestyle modifications and not say we need to move you toward medication. On the contrary, if someone has a high ASCVD risk and their blood pressure may be 140 or 145, and I may say, you know what, we can lower that risk by 28%. So here's where you are on your ASCVD risk. We can lower it by this much. How does that sound? That's kind of how I approach it. And it's much more in line with treating blood pressure as a continuous variable as opposed to a threshold. The metric question, that's a good one. I think the 140/90 in the clinic is probably the best we can do in the clinic. home blood pressure is when you can incorporate them into I don't know if you're doing that in your EHR or have a strategy for that. That gives you some kind of like way to get that a little more accurate, I think.
You have measures like blood pressure load or hypertension load.
Yeah.
Is an average or a time and range or anything like that, you think a better predictor?
I think it would be a better predictor. Alan Hinderleiter from UNC are writing a paper now. It's actually it's revise and resubmit on using home blood pressure load as a measure. So that hopefully will be out in a few months. But we looked at that because part of the frustration with home blood pressure and why we even thought of using home blood pressure load to begin with was the sheer challenge of someone coming in with their tissue paper with all their readings on it of their blood pressure and trying to figure out what to do with them. But seriously, if they wrote it down and had the readings even written down in the form where you could just simply count the ones above and what threshold do you use for that for it to say you're in control or not. So that's what we're looking at now. And we've got a similar kind of idea here. What does that look like when you look at ROC curves and things like that? So I think that time and range is, and maybe that's what we'll get when we can actually have people wear something. Yeah.
I'm just curious in terms of antihypertensives. For patients who have white coat syndrome who are being misdiagnosed or overtreated.
Yeah.
What's the risk factor for moving towards medication treatment, even if it's overtreatment? And in terms of pharmacological management, how many are those papers based off of looking at blood pressure reduction in clinic, or are they measured against ABPMs?
Yeah.
So will this change management for antihypertensives?
Right. Most older trials are not use clinic blood pressure. Most older trials also had a much higher number. And so you start there. Modern blood pressure trials pretty much have to have ABPM in them, partly because we're using much lower numbers. Moving the needle, or I'll say it this way, we are doing a lot of good when we take somebody from 170 to 150. We're doing a little bit of good when we take somebody from 150 to 140. We're barely doing any good when we're taking somebody from 140 to 130, right? That's so you're doing good up here. White coat hypertension, the reason overdiagnosis or overtreatment of it is because then you take someone who doesn't have high blood pressure and the benefit for them isn't there. And we've shown you don't even move the needle very much on blood pressure ambulatorily in white coat hypertension patients. And then you're giving them hyponatremia, hypokalemia, angioedema, and they didn't even need treatment to begin with. And so, not to mention the label, the cost, the inconvenience, those kind of things. So I think that's the reason. Would there be if those patients do take blood pressure medicine, might it confer a benefit? Yeah, it might confer a benefit, but it's small. And it may not outweigh the potential risks.
One final question I had is based off of what you were saying about examining other factors like left ventricular hypertrophy. Why are we even focused on blood pressure at all then? Or should we have an entirely different approach to sort of evaluating healthy patients? And is our fixation on blood pressure kind of looking at a cause, not necessarily the symptoms that we want to even be treating anyway?
Yeah, that's a great question. And blood pressure, after all, is only a risk factor, right? And high blood pressure, I mean, and we're using it as a marker of other things. Could there, if you had an A1C of endothelial health, would that be better? Probably. We don't have it yet. I took the data, this first data set I had, we also had a blood sample that we stored from all the participants. And my goal there was to look at something that could serve in that regard. Could we find a marker of endothelial health that's changeable, like an A1C, that says if you measure it now and it's this high, you give them medication and it comes out 3 months later this level, could you find something like that? We looked at microparticles, which are shed by endothelial cells. That was not a good marker. And I can tell you the reason there is so many other things affect the shedding of microparticles, not just shear stress from blood pressure. So that's to say that I'm with you. The current work I'm doing is looking at using impedance cardiography to figure out what's driving high blood pressure, and then using that one to guide which blood pressure medication you actually select for the patient. Don't give them an agent that's going to reduce their systemic vascular resistance if their problem is hyperdynamic heart or volume overload. Give them the medicine that matches the pathophysiology. So that's one, and then the question becomes, if that works, then yeah, you can measure blood pressure as the outcome, but guess what you could also do? Measure the hemodynamic profile as the new target. So that is a whole other line of research that we haven't done yet, which is the current base of some preliminary data I'm doing now, and the next R01 I hope to put in is using ICG to guide medication-naive patients to give them the target medication that matches what's going on with them. And the next question after that is, now I fix the blood pressure or whatever we're measuring that we're calling blood pressure. And then what if I fix the systemic vascular resistance and dial that down again and get it controlled? Does that patient even have fewer CVD events? So yeah, I'm with you.
Thank you so much.
Yeah, thanks.